بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Hello everyone. Today's lecture is about the hypertensive retinopathy. This lecture is prepared by my professor, Professor Dr. Magdi Tawakkul, Professor of Ophthalmology at Al-Azhar University, Cairo, Egypt, and me, Hussam Ziada, Assistant Professor of Ophthalmology at Al-Azhar University, Cairo, Egypt. So first of all, I want to thank my professor, Dr. Magdi Tawakkul, for giving me his kind support and allow me to give this lecture after him. Thank you, sir, for your kind support. So today we will talk about the hypertensive retinopathy. Starting with a brief introduction about the hypertension, which is one of the most common worldwide diseases affecting humans. The normal blood pressure could be 140 systolic and 80 diastolic. This is a range. It is not a fixed figure. This is a range for the systolic blood pressure and the diastolic blood pressure, but the normal blood pressure is defined when the systolic blood pressure is at 140 or less, and diastolic is 80 millimeter mercury or less. So hypertension is the high blood pressure, which is higher than this number. But about the average and the common readings of the blood pressure could be around 120 systolic and 80 diastolic. So blood pressure is a force of blood against the artery wall as it flows through them. A patient is said to be hypertensive when his systolic blood pressure is equal to or higher than 140 millimeter mercury, and diastolic blood pressure is higher than or equal to 90 millimeter mercury, that the patient is not on antihypertensive drugs. Classification of the hypertension, there are etiological classification. The etiological classification of the hypertension is either essential hypertension, which is mostly idiopathic, and secondary hypertension. The essential hypertension is almost idiopathic with no known cause. The blood pressure is regulated by the renal, hormonal, vascular, neurologic systems. So the secondary hypertension, in this type of hypertension, the etiology of the high blood pressure can be identified, which could be due to renal disease, endocrinal disorder, or neurogenic disorder. Could be also mechanical, exogenous, or miscellaneous causes. So it's common in the younger age. So we have to search for or to look for the secondary cause, primary cause for the secondary hypertension. The complication of the hypertension, that it thickens the heart muscle. This occurs with time, leading to a left ventricular hypertrophy, ischemic heart disease, heart failure at the end, stroke, kidney failure, loss of reduced vision, trouble with memory, hence loss of or reduced vision. This is our topic, trouble with memory and raised metabolic syndrome. So remember, one of the complications of the hypertension is the loss of vision or reducing the vision. Also by its affection on the cerebral circulation may affect the vision, secondarily from the central nervous system. Based on recommendations of the 7th report of the Joint National Committee of Prevention, Detection, Evaluation, and Treatment of High Blood Pressure, the classification of blood pressure for adults aged 18 years or more is as follows. It could be normal when the systolic blood pressure is less than 100 20 and diastolic is less than 80 millimeter mercury. Pre-hypertension, when the systolic blood pressure is from 120 to 139 and diastolic from 80 to 89 millimeter of mercury. Stage 1 hypertension, when the systolic blood pressure is 140 to 159 and diastolic from 90 to 99. Stage 2 hypertension with systolic is more than or equal to 160 and diastolic is more than or equal to 100. So I'm talking with in this lecture, which is related to the ophthalmology. I'm talking about the hypertension because it is the base. You have to get a background about the disease which could affect the eye to know about. What are the causes of the hypertension? As you see in this drawings, it may be hereditary factor related to the family history and the family factor, related to or secondary to obesity, which may lead to hormonal disturbance, or a sedentary lifestyle, where there's lack of exercise can cause high blood pressure, yes. Although the stressing life, the chronic stresses, especially lead to chronic increase of the blood pressure. So the patient may be a hypertensive one. Other causes could be kidney disease, adrenal gland tumors, increased salt intake. It's a bad food behavior, tobacco use, alcohol abuse, stress, certain medications, and so, and extra causes. Symptoms and signs of the blood pressure is, it could be usually asymptomatic, and this is a big problem with the hypertension. The hypertension may pass asymptomatic for a time. So it's called silent killer, because you may have no symptoms or signs for the hypertension until you have a complication regarding the stroke, cerebral stroke, heart attack, or loss of vision. About the other causes could be breathlessness, headache, bleeding from nose, fatigue and sleepiness, profuse sweating, blurred vision. These tips could be beneficial to know about the common tips or the diagram how to control the hypertension. The first of all is to correct your lifestyle, to eat less salt, to do exercise, stop smoking and alcohol, to have a healthy diet, and to reduce your weight. And also to regard and consider any changes in your mood and changes in your feelings, to check for the blood pressure and to know if you are within normal or not. So let's go ahead to our topic today, which is the effect of the hypertension on the eye. In this photos, you will find the upper left fundus, the upper left photo for the normal fundus. You will see that the blood vessels are smoothly regulated and passing throughout the central and mid-peripheral retina with no narrowing, with no crossing. They are almost the normal and passing smoothly, forming this vascular map in the fundus you will see when you examine your patient. Down on the left side, there is some sort of the vascular narrowing. Hence, the blood, the retinal veins, which is brighter and thicker, and the retinal arterioles and arteries, you will find that there is a narrowing. If you compared the lower photo with the upper one, you will find that the veins and the arteries in the upper photos are equal in the diameter and its caliber elsewhere. but down you will find that the veins is still is still keeping its lumen or caliber, but the arteries here in the down photo became narrower and thinner. So one of the features you may find in the fundus of the hypertensive patient, you will find the vessel narrowing. Also, one of the other signs is the arteriovenous crossing. You will find that the arteries are crossing above the veins. The veins is engorged and tortuous, but the vessels narrowed and a little bit stiffer, so they are crossing and dipping the veins, forming this photo you'll find in the middle. So the hypertensive retinopathy consists of a spectrum of retinal vascular changes that are pathologically related to transient and persistent microvascular damage from elevated blood pressure. The hypertension-related changes in the eye may be hypertensive retinopathy, also choroidopathy, also optic neuropathy. So the hypertension can affect the retina, choroid, and the optic nerve. So here I will count in enumeration better the fundus changes which could be found in the hypertensive patients. Prolonged systemic hypertension results in retinal vascular effects, vessel narrowing, arteriovenous crossings, microaneurysms, hemorrhages, cotton wool spots, macular star, and papilledema. So please memorize all these changes which could be found in the hypertensive related fundus changes. Chronic hypertension with significant elevation in diastolic pressure directly related to narrowing of the caliber of the blood vessel, because it yields a resistance against the circulation. So the diastolic is related to the to the resistance and to the narrowing of the caliber of the blood vessels. Arterial narrowing is judged by comparing the caliber of artery with that of adjacent retinal venule, as I told you with the previous photo. Atherosclerosis and elevated diastolic blood pressure minus the vessel wall hyperplasia, also the fibrosis and luminal narrowing. So the atherosclerosis is related to the narrowing because the atherosclerosis decreases the lumen and leads to narrowing of the blood, the lumen of the blood vessel, increasing the caliber, and so increasing the resistance and increasing in turn the diastolic blood pressure. So the systolic blood pressure is related to the pump of the blood from the heart itself. So it's more related to the heart rate, while the diastolic is related to the narrowing and resistance of the circulation of the blood vessel, lumen, and the calibers. So in these photos, you see now the hemorrhages and the microaneurysms elsewhere in the peripheral and the mid-peripheral retina, and the hemorrhages all over the fundus. These are changes could be found with the diabetic retinopathy, but also they will be found as an abrupt changes in the hypertensive retinopathy. But with the diabetic retinopathy, it will take a long time, very long time to happen. But in the hypertensive retinopathy, especially the hemorrhages, you will find them if you have a patient with a malignant hypertension or sudden rise of the blood pressure. The retinal arteriole and venule share a common adventitial sheath in the area where they cross each other, and artery compressed vein, which is arteriovenous necking and nipping. I will show it again in the coming photo. Compression of vein leads to venule deviation and vein humping. Yeah. Also, one of the signs is the banking, distal dilatation of vein, proximal narrowing of vein. Banking because of pressure on the part of the vein. You will find the stagnation of the blood distal to this pressure, and narrowing of the vein proximal to it, because of the pressure will increase the resistance to the flow of the circulation through these venules. Small round dark red dots on retinal surface, also best detected on the fundus fluorescein angiography. And these red dots on the retinal surface are an indicator for the aneurysms, beginning as dilatations in areas in capillary wall where pericytes are absent. Initially, they are thin, pooled, and later endothelial cells proliferate and lay down layers of basement membrane material around themselves. So there is increase in the number at the degree of retinal involvement, and also increase in the number of the capillary occlusion and retinal ischemia. This leads to finally the microaneurysms and the dot hemorrhages, and after that the intraretinal hemorrhages. The hemorrhages occur superficially in the nerve fiber layer, so they are arranged and taking the pattern of the nerve fiber layer, so they are called flame-shaped hemorrhage because it's a streak appearance following the arrangement of the nerve fiber layer, like the flame. This may lead to macular edema and subsequent vision loss, finally. It's a result of chronic hypertensive damage to the capillary wall endothelium, extravasation of plasma from the lumen into the extracapillary space. So let's collect all of the previous slides in this photo. This is the ophthalmoscopy of a patient with malignant hypertension. It's an acute changes. By the way, I have seen such patient last week in my clinic. He was not known to be hypertensive, but he experienced a severe headache with loss of vision, and he accidentally diagnosed as a hypertensive 1 with a sudden rise of the blood pressure up to 220 millimeter of mercury systolic and 100 diastolic. So there is a rapid deterioration of the eye and his vision. So I found in the fundus all this picture. The macular scar, there is an exudation around the macula, taking the arrangement of the macular fibers, so giving this macular star around the fovea. Also the cotton wall spots, all these white spots are ischemic and ischemic parts and infarcts in the retina, in different parts of the retina. So they are called cotton wall spots. Also edema of the optic disc, leading to the disc edema, which is called papillodema. But the papillodema or papillites, both terms are different. The papillites is related to inflammatory process, but papillodema is leading to the passive edema. And in this situation, it's not inflammatory process. It's due to stagnation of the circulation and leading to the disc swelling. It's a part of the papillodema, but it's not related to the central nervous system. So it couldn't be defined as classically as papilledema because there is no increase in the intracranial tension. So you will refer to it as disc edema and hypertensive papillopathy. So you will find the macular star, the cotton mole spots, the disc edema, and you will find the microaneurysms and dot and flame-shaped hemorrhages all over the retina, according to the severity. And you will find a very important sign here to differentiate between the hypertensive retinopathy and the central retinal vein occlusion and other pathologies is the narrowing of the blood vessels, of the arterioles. You will find that the arterioles are so narrowed and the veins may be of the normal or increased size and leum due to stagnation and engorgement. And you may find a crossing of the arteriovenous, of the arterioles with the veins, with nipping and nicking and banking, with proximal narrowing and distal dilatation. All these signs will be correlated clinically with the symptoms and signs with the paralysis, with the unconsciousness, with the blindness and nephropathy. So you will diagnose it as a hypertensive retinopathy. So the cotton mole spots, which were shown in the previous figure, they are chronic hypertension changes with arteriolar sclerosis, the arterial occlusion with the focal ischemia, formation of soft exudates. So the cotton mole spots are soft exudates due to infarctions and focal ischemia. Macular star, deposition of lipid in the handless layer. Yellowish white exudates accumulate in the macula in hypertensive retinopathy and take an appearance of a star. It's different than that of the diabetic retinopathy. Papilledema, I think I have talked about it. It's unilateral swelling of the optic nerve head, unilateral swelling of the optic disc head. So it could be part in differential diagnosis of disc edema due to direct effect on the optic nerve or its blood supply. It's an important sign of the malignant hypertension. So grading of the hypertensive retinopathy by the Keith and Wigner on 1939, they have classified the hypertensive retinopathy changes into 4 grades. Grade 1, mild. Grade 2, marked or moderate. Grade 3, severe. Grade 4, it's an emergency. The mild generalized anterior, grade 1, mild generalized anterior attenuation. Grade 2, there is marked generalized narrowing with Sola sign. Grade 2, copper wiring, bonnet sign, gun sign, flame hemorrhages, cotton mole spots, and hard exudates. And the grade 4, finally, in addition to the previous finds in the grade 3, the silver wiring, not copper wiring, silver wiring and papilledema. So I think you were asking about the Sola sign. Sola sign is the right angle deflection of the veins at the arteriovenous crossing. Right angle deflection by the nipping and the pressure on this point of the veins, you will find that the deflection of the veins will be acquiring a right angle at the point of arteriovenous crossing. The bonnet sign, banking of veins, as I said, distal to the nipping, and this is called bonnet sign. And the gun sign, tapering of veins on the proximal part of the nipping. So on the nicking and nipping, there is a bonnet sign distal to it, and the gun sign proximal to it. Another photo for the all grades, there is a generalized attenuation. There is a marked cotton wool spots. There is a flame-shaped hemorrhages. There is papilledema, different forms of the acute hypertensive retinopathy. So, in addition to the hypertensive retinopathy, there is another pathology in the ocular changes with the hypertension is hypertensive coridopathy. It's a rare, but it may occur as a result of accelerated hypertension in young adults. Choroidal vascular bed shows impaired circulation and extensive occlusive and ischemic changes. As you see, there is a cheek-raised streaks may be found in this photo in the macular area and also the peripheral and the mid-peripheral retina. You will find that there is something behind the retina on the scale of the choroid. There is also Elshing spots, small black spots surrounded by yellow halos. It represents focal choroidal infarcts, like that of the cotton wool spots. Then the sick wrist streaks, or shake wrist streaks, as in some pronunciations, they are linear hyperpigmented streaks or flecks arranged over choroidal arteries. So the changes in the choroidopathy may be Elshing spots, sick wrist streaks, also the exudative retinal detachment because of the exudation in the choroid, which may left the retina, causing a retinal detachment, but it's not rhegmatogenous or free. Retinal detachment is related to the exudation from the choroid. It's called exudative retinal detachment, and this exudative retinal detachment needs no surgery, just to treat the primary cause. And then when the exudation disappears, the retina will go back to its normal position. Sometimes this may happen bilaterally and may occur in severe acute hypertensive retinopathy. I have seen like this picture in the severe cases of preeclampsia in the pregnant woman. So it's very common in such cases, and also in the severe forms of the autoimmune choroiditis, which may lead to severe exudation with retinal elevation, but there is no tear in the retina, and there is no traction on the retina, so it's exudative retinal detachment. Hypertensive optic neuropathy also, it's not common like the hypertensive retinopathy, but it will be in the form of optic disc edema, which has been described as an essential manifestation of the malignant hypertension. It's a grade 4 hypertensive retinopathy, and it's one of the signs of the malignant hypertension. Optic disc edema is initial manifestation of the hypertension. Initial manifestation, sorry, it's mistyping, but it means the malignant hypertension. One of the initial manifestation of the malignant hypertension, sudden rise, sudden, very marked rise in the blood pressure. And our studies indicated that, all studies indicated that the hypertension, the malignant hypertension, represents a form of ion. This abbreviation, ion, represents the arterial ischemic optic neuropathy. Arterial ischemic optic neuropathy, which is idiopathic with unknown cause. This may lead to prolonged ischemia related to the deficient circulation or the atherosclerosis or the other cause like the hypertension. So the optic disc edema, which may occur with the hypertension, it doesn't occur with the hypertension as a chronic sign, but it will happen as one of the initial signs of the malignant increase of the blood pressure. Also, it may lead to finally to the ion, which is arterial ischemic optic neuropathy, which will lead to optic atrophy and loss of vision in this eye. So the conclusion of this presentation will be that the hypertension is one of the very, very risky diseases which could affect the eye, one of the chronic diseases which could be considerable in dealing with the eye. It needs, like the diabetes, follow up with the fundus to check the fundus changes, which may denote that the blood pressure is well controlled or not. Also to identify the expected prognosis for this eye with this systemic disease. I hope it clear and beneficial presentation covering everything about the hypertensive retinopathy. So send your patients to their internists to check for the proper control of the blood pressure and tell them that it's highly recommended for them to follow up 6 monthly or 1 yearly at least with fundus examination to check for changes of the hypertension related retinal, choroidal, and disc changes. And thank you very much for your attention.